So thank you very much for that introduction, and thanks to Lisa and the team from hFRenDs for inviting me to speak to you this morning. And I'm really pleased to be here. It's a great privilege, and I'm pleased for two main reasons. One is there's so much synergy, I think, between what you're doing with hFRenDs and what I'm trying to do with CaReMe UK. But you're ahead of the game, so this is your second live meeting, which is brilliant, and that's something that we are aspiring to do in CaReMe UK. And the second reason is it's brilliant to talk to a nursing and specialist nursing forum. And I know from my work with the heart failure nurses and diabetes specialist nurses and nephrology nurses back at my home institution in Leeds how wonderful you all are. And that was a pleasure to be at the Association of Cardiovascular Nursing and Allied Health Professionals in Edinburgh a couple of weeks ago and saw some of the really amazing initiatives that are being driven across Europe, really, based on specialist nurse activities and passion and drive. So it's really a great time to be here and be speaking to you. So without further ado, I'll just put up a conflict of interest slide. So I'm a cardiologist. My day job is treating patients with coronary heart disease, so I participate in the heart attack service for West Yorkshire. And one of the things that's always struck me working in cardiology is the impact of diabetes or chronic kidney disease on outcomes in the patients that I see on a day-to-day basis. So this slide just illustrates, for instance, the effects of what we see when our patients have diabetes and heart attacks in combination. So when I go around coronary care, I have to be mindful of this, that in a typical person of age 60, for example, the presence of diabetes will lead to a 6 years loss of life expectancy. But if that person has diabetes and then a heart attack, we're looking at 12 years loss of life expectancy. So we need to think about what tools we have now that we can use to try and improve these statistics. And it's the same with the cross-cutting effects of diabetes and chronic kidney disease. And this paper here, many others that are similar, show that the combination of diabetes with even early chronic kidney disease predicts a shortened life expectancy of over 16 years. So these are all bad news, but there are things that we can do to improve that, and that's why we're all here today. So part of my job is research, and I'm really interested in looking at some of the underlying molecular mechanisms for why we all see people with combinations of kidney disease, heart disease, and diabetes. And I think it's quite clear now that there's a sort of genetic predisposition and environmental exposure, which leads to abnormalities in multiple aspects of our body's regulatory systems, including inflammation and insulin resistance, and activation of the renin-angiotensin system. And this is at the heart of all of these three conditions. So it's not surprising, really, that all of these three conditions coexist. And it's also perhaps not surprising that some of the treatments and tools that we have work across all three of the conditions. So cardiorenal metabolic disease is very common. So we know, again, when I go around my coronary care ward round, that over a quarter of my patients will have diabetes. And in fact, if we drill down into that more deeply and look at insulin resistance and glucose intolerance, then actually the majority of patients with coronary disease will have some type of metabolic dysregulation. When we look at patients with heart failure, we know that at least a third of those also have diabetes. And when we look at patients in the community with heart failure, we can see that 61% of those in this UK National Heart Failure Study had some degree of chronic kidney disease. So this spectrum of disease is very common, and it very commonly affects people having multiple components of cardiorenal metabolic disease. Now the question is how we can tackle that and who is best placed to tackle that. And part of the work that I was leading with CaReMe UK and locally in my own hospital was trying to upskill cardiologists to identify and recognize cardiovascular disease and diabetes. And I'll tell you a little bit more about that in a moment. But these data are from the United States. I'm sure there'll be very similar data in the United Kingdom. And these are data from two large healthcare systems within the US. And what the investigators did was just looked at medical contacts. So these were outpatient contacts with medical teams in patients with type 2 diabetes. And on the left, we have patients with type 2 diabetes, and on the right, we have type 2 diabetes with CVD. And you can see that there's an awful lot of contacts with primary care, as we might expect. And I'll touch on that in a moment about how really community teams and primary care teams are really important in terms of tackling and preventing poor outcomes in cardiorenal metabolic disease. But if you look at secondary care contacts, you can see that actually patients with type 2 diabetes were twice as likely to come to a cardiac clinic rather than diabetes or endocrinology clinic. And if they had cardiovascular disease, then much more likely, 4 times more likely. So part of the work we've done with CaReMe UK is to try and see how we can upskill cardiology teams across the board to try and recognise the effects of renal disease and diabetes, and either start to manage that or cross-refer so that it can be appropriately managed. Now, as I've said, my day job is treating patients with heart attack, and these are some data from my own centre. So this is the West Yorkshire Heart Attack Service, and these data are quite old now, from 2012. But we looked at outcomes in patients who had primary PCI for STEMI. So this was sort of state-of-the-art reperfusion therapy. And what we see is that the patients with diabetes, in the top line here, their mortality is much higher over long-term follow-up than it is in patients without diabetes. Now, of course, this is 11 years ago, and we've had improvements in care and pharmacological management since then. But if we look at more recent data sets, we still see the same persisting treatment or outcome gap, that patients with diabetes do much worse, both in terms of mortality, reinfarction, and hospitalization and heart failure hospitalization. So these are really big problems for patients with diabetes, and we'll see the same kind of pattern in patients with heart attacks and chronic kidney disease. This slide shows the impact of diabetes as an example in patients with acute heart failure. And again, we see that the adverse impact of diabetes is not just in heart attacks, but in people admitted with heart failure, when we see that people with diabetes doing much worse in terms of mortality and heart failure hospitalizations. And we see here the impact of diabetes and chronic kidney disease individually and in combination on outcomes in this very large study. And this slide shows the event rate per 100 patient years. And if you look at heart failure, for example, we see in a patient without diabetes or kidney disease, the event rate 8.6. But if patients have diabetes and CKD, look at this, the event rate 52. So a massive increase in risk of heart failure. And we see the same thing with myocardial infarction, risk of renal replacement therapy, and mortality. So there's a huge gap here in terms of modifying risk in patients with diabetes, CKD, or particularly combinations of the two. So that was quite depressing, but what do we do about it? So having depressed you for the first 5 minutes, then we want to sort of up the ante and see what we can do to cheer us all up and see how we can improve outcomes for these patients. So things have changed a lot in terms of my time in cardiology, and we do now have a big toolkit both across cardiovascular disease, renal disease, and diabetes that we can deploy to improve outcomes. So we have all the tools. We've got lipid modification, we can give injectable therapies, we've got treatments for diabetes that will reduce the risk of heart failure or cardiovascular events. We can extend antiplatelet or antithrombotic therapies in patients with acute coronary syndromes who are at high risk. We can prevent or delay the progression of kidney disease with RAS inhibition and finerenone. And we know that there's the 4 pillars of therapy for heart failure, and we've learned recently how we can sequence those and get people on board these medications much more quickly, and that will therefore reap benefits in the long term. So we've got all these tools, but the problem is that in many cases they're staying in the toolbox and not being taken out to actually help improve the outcomes of patients. And there are many examples I could think across all of these, where many of these medications which have got nice technology appraisals, they're approved for use, but they're not being used, at least not sufficiently, in the right numbers of patients. So this is just a couple of slides from the
CaReMe tool. So this is great. I don't know if any of you have tried using this, but if you log on to the CVD Prevent website, you can actually look at cardiovascular prevention rates and updates of medication in your own locality. So these data are for the whole of England, and I've just picked a few snapshots, so I'm not expecting you to read these slides, but on the left, look, this is adult patients who don't have CVD but have got an elevated Q risk, so would be eligible for a statin, but less than half patients are actually taking a statin. This is patients with CVD who should be on a statin and should have aggressive lipid lowering, but actually only a quarter have got their lipid profile treated to target. And these are quite conservative targets. These are not the stringent ESC targets. And these are the patients in primary care with hypertension who've got blood pressure readings that are below target. And again, we can see that we're really not achieving that in large numbers of patients. It's slightly better when we look at CKD. So if we look at patients with recorded CKD, hypertension and proteinuria on a renin-angiotensin system antagonist, then we're reaching almost 70%. And we've got similar levels of uptake of blood pressure control and of 85% of patients with CKD having had an EGFR carried out over the last 12 months. Now, of course, these data will be impacted by COVID, but even if we look at historical data prior to COVID, then many of these facts remain the same, that we were just not deploying fairly simple, straightforward risk factor modification that is really very achievable. Now, why is that? And this slide is up for discussion, but I think one of the main issues in which we work in terms of the healthcare system in the UK is that resource is very much pushed towards crisis management and acute problem firefighting rather than long-term population health and disease prevention. And I've shown this across the spectrum of heart failure, cardiovascular disease, kidney disease and diabetes. And I think those of us who work in hospitals or specialist units will realise that we spend most of our time dealing with acute events or expensive treatments for patients, including management of heart attacks and revascularization, device therapy for heart failure, transplantation and dialysis, and complex diabetes management. But actually, what affects most of our patients and what will stop people reaching this tip of the iceberg is management here. This is the unseen people who are at the bottom of the iceberg, who've got risk factors that are just not being identified and not being controlled. And we've got epidemics of obesity, untreated hypertension, undiagnosed CKD, and we can do things about all of these aspects. So one of the problems we've had historically is that we've loved working in these silos. So I think it's right in saying that historically we've all tended to work fairly independently in a specialty-specific manner. And although within our silos we're quite good at collaborating, so I think in each silo we're brilliant, so that we can collaborate and we can have specialist nurse teams and pharmacist teams and allied health professionals and very good pathways of care. But the problem is that they don't cross-connect. And the issue with that is that much of the time we're actually treating the same patients, and the patients are dropping into each of these silos in and out. The second thing is that we're treating the same risk factors. So many of the patients who are dropping in and out of these silos, we need to be tackling their blood pressure, their weight, their exercise, their diet. We're giving the same lifestyle advice to do this, and we're often, in many cases, using the same medication. So there's a need really for more joined-up thinking to try and break down this silo mentality. And we've also got this silo mentality, I think, in the way that healthcare is delivered. So there are big barriers that persist between primary care, community care and secondary care. And we've seen this, I've seen this firsthand in trying to set up cardiorenal metabolic services and clinics locally. It's really difficult to try and bridge the gaps between primary care, community and secondary care. Now there are examples of where that works really well. And I know in Leeds we have a fantastic heart failure service that is integrated across the community, primary and secondary care. But we don't see that wholeheartedly across the whole of the cardiorenal metabolic spectrum. And that's something we need to solve, because it wastes resources. We're treating patients differently in different settings. it wastes expertise and opportunity. We could be sharing best practice and sharing knowledge much more widely. And this is bad for patients. So I think all of this needs to change. So the good news is I think it is changing, and the reason I think that hFRenDs exists and CaReMe UK exists probably dates back to this man. So this is Steve Nissen, who's a cardiologist in the US, and he published this paper back in 2007, which caused a bit of a storm, saying that the diabetes drug rosiglitazone, which was very widely used at the time, led to an increased risk of heart attacks. Now, in fact, he was probably wrong, and looking at the evidence in totality, I don't think it did lead to a risk of heart attacks, but what this did was led to a change in the regulatory authorities requiring outcomes trials to show that diabetes drugs were safe for cardiovascular patients. But what those trials showed was not only that many of the drugs were safe, but that some of them actually improved outcomes, and some of them improved outcomes in a fairly dramatic way. And that led to the development of SGLT2 inhibitors, for example, to be used in heart failure and in chronic kidney disease. And it led to shifts in guidelines that we're all now aware of. And I think that change in practice and that bringing together of cardiorenal metabolic disease is what led to the creation of CaReMe UK. So CaReMe UK, the first thing to say is we're not an independent society. We are simply a sort of expert reference group. So CaReMe UK is basically a partnership or a collaboration between these societies. So these are many of the UK societies spanning heart disease, kidney disease and diabetes across primary and secondary care. And we've got a bunch of volunteers. So these people work within each of these societies, and we get together and we try and improve outcomes for patients with cardiorenal metabolic disease by working together. Now it is a process of evolution, so CaReMe UK has been in existence for just over 3 years. I've been lucky enough to chair it for the last year. And what we do is partly advocacy, so we try to emphasize the importance of what I've been saying, the huge risk we're seeing attributable to mixtures of cardiovascular disease, diabetes and kidney disease, but also advocacy for the patients with those conditions and how we can actually prevent these conditions progressing and improve outcomes. We spend a lot of our time responding to consultations, NICE guidelines, updates, protocols, calls for evidence. We published a couple of best practice guides that are on our website, looking at cardiovascular risk management in cardiovascular disease and diabetes and heart failure management. And we've got more to come, so there are others that are in development at the moment. And we spend a lot of our time in education, so we've run sessions trying to bring together cardiorenal metabolic aspects of care at specialty meetings. So we've infiltrated the British Cardiovascular Society, the UK Kidney Week, we ran a session there quite recently. We ran a session at Diabetes Professional Care last year where we had a sort of drop-in workshop on cardiorenal metabolic disease. And we're also trying to influence training, so this is a work in progress, but I have a meeting coming up with colleagues from the Royal College of Physicians in a few weeks' time to look at how we can try and embed cardiorenal metabolic aspects in the training of future specialists in terms of cardiology, renal medicine and diabetes. We try to share best practice, and again this is a work in progress, but we try to collect examples. So these are examples of cardiometabolic clinics that we are running across the country, and there are more because this is expanding. And of course there are many, many examples of cardiorenal clinics and of diabetes kidney clinics which are already in existence across the country. Our ambitions for the future are to do this, so we would very much like to have a national conference, and we've got the go-ahead from the British Cardiovascular Society, under which we sit, to hold a conference next year. And as part of that, we want to bring together a national network of healthcare practitioners interested in cardiorenal metabolic disease, and also expand that to a cardiorenal metabolic UK research network. And through doing this, I'm sure there are huge opportunities for collaboration between CaReMe UK and hFRenDs, and I'd really like that to happen. So that's something that definitely I think we can take forward. So a little bit about what I've been involved with locally. So one thing we've done locally and at CaReMe UK level is to try and see, recognising that we want to make every clinical contact count. So we know, as we've said, that many patients with type 2 diabetes contact cardiology teams. So we tried to upskill cardiology teams to see if they can improve diabetes care. And really, this is focused on the simple stuff. So we can look at what therapies they're on. We can try and introduce and optimize therapies with SGLT2 inhibitors. We can't do the complicated stuff. So I think it's fair to say that cardiology teams cannot do all of this, and this is where we need well-built collaborations between cardiology teams in hospitals and the diabetes specialist nurses, and that works really well. But there are still opportunities where patients come to outpatient clinics or get admitted with acute coronary syndromes where we can optimize care. We did a survey of cardiologists back in 2019 to look at their experience and thoughts about managing diabetes in patients with acute coronary syndrome. And we saw that there were various levels of familiarity with the evidence base for SGLT2 inhibitors and GLP-1 agonists. And we saw that, I'm sure you'll be pleased to see that the cardiologists felt the most suitable person to deliver diabetes treatment in hospital were the diabetes specialist nurses. And it was reassuring to see that 79% of them thought that diabetes was a really important risk factor that needed to be addressed and needed to be modified. So I'll spend a few minutes talking about an initiative we've driven at Leeds, and this was setting up a cardiometabolic clinic. So this was a secondary care clinic looking at patients following myocardial infarction. And we did this because this was an audit carried out by a colleague of mine, Rani Khatib, consultant cardiology pharmacist in Leeds. And he did this audit of patients with myocardial infarction. And I won't dwell on this, but suffice it to say, what we saw at the time was that glycemic control from admission with a heart attack to 12 months later actually worse in the majority of patients. And there was a pretty low uptake of medications such as SGLT2 or GLP-1s. Now this predated the license for heart failure and kidney disease when we did this audit, but there was the evidence out there for cardiovascular benefits for these agents. So we wanted to tackle this problem, and we explored all these different opportunities in terms of timelines of people after a heart attack, of where we could intervene, and the various healthcare providers who could potentially intervene. And of course, this is a big piece of work, and really, we need to tackle the whole of this. So part of what we've been doing in Leeds is running educational sessions for all of these stakeholders to try and improve uptake of risk factor modification in patients with heart attacks and diabetes. But we set up a dedicated post-MI clinic. And we did that. It was quite hard work. We had to bring together lots of stakeholders. We had quite a bit of time persuading our commissioners at the time, now the Integrated Care Board, in terms of the value of expanding uptake of medications in patients in this group, because this predated the publication of the NICE guidelines on diabetes management. So at this stage, there was no NICE guidance for using SGLT2s for CVD protection. But we succeeded, and we set up a clinic. We built it on a pre-existing model in Leeds. So Rani Khatib had set up a very well-developed pharmacist-delivered clinic for patients with MI. And in Leeds, patients with MI are triaged either to a consultant-led clinic, or the majority go to a pharmacist-led clinic for risk factor optimization. And this has been hugely successful and led to publications and recognitions by NICE. So we used that model. We wanted to try and set up a cardiometabolic service that provided a sort of one-stop model where we could spend time with the patients and talk about their cardiovascular risk and diabetes management in one setting. And this is the structure. So we were lucky enough to bring together Rani, myself, and Ramzi Ajam, who's one of the diabetologists in Leeds, and we set up a dedicated clinic. And again, we have a small number of patients triaged to a joint cardiovascular diabetes clinic run by Ramzi and myself. The majority come through here to a pharmacist-delivered clinic. And we're evolving this model. So one of the things we're doing now is moving, as well as having pharmacists delivering the clinic, to having specialist nurses delivering the clinic. And we try and tackle the whole of the gamut of cardiovascular, diabetes and renal management in terms of what we can satisfactorily achieve at a basic level, and then if there's more complex disease we can refer out. So in the interest of time I'm just going to skip through some of the outcomes, but I'm happy to talk to you about these later. These are all preliminary at the moment, so we're in the process of looking at these outcomes in more detail, but we saw improvements in glycemic control, lipid modification, weight and blood pressure control, and we were able to optimize therapy in terms of increasing the uptake of SGLT2 inhibitors, GLP-1s, and also in 75% of cases we're able to advise on extended antithrombotic regimens. And the patients like it. So again, these are just some of the patient-reported outcome measures. It's a busy slide, but the blue bars show that people agree with our questions, that they felt they were more able to understand their diabetes, understand their cardiac medications and control their risk factors. And in the majority of cases, we were able to tackle lifestyle management, look at medication adherence, and talk about the holistic management across the diabetes, kidney, and cardiovascular spectrum. And here's just a few snapshots of what patients felt. They felt it was reassuring and supportive. And in terms of complete satisfaction, we got 8.8 average score. Only one person was completely dissatisfied. So where are we moving from this? Well, we like the idea of optimizing and using the whole workforce, so we chose a pharmacist-based model because that's what we have experience of, but we're moving into now our specialist nurse-delivered clinics. We try to make it a one-stop service, and we want to sustain this. So what we're trying to do now is to see how we can further this and deploy this within the Leeds community and across primary care. And that's proving a little bit more challenging. We've got ongoing pilot projects, which are being run by some of my colleagues in Leeds in terms of heart failure, and they've been very successful. So having community heart failure nurses working with PCN pharmacists to help optimize heart failure management and deployment of the 4 pillars of therapy. But we recognize that many of these patients with heart failure actually had renal disease and diabetes that needed addressing as well. So we're now developing bids to try and get a more holistic community approach based to CaReMe management within Leeds and West Yorkshire. So just to finish off, a few thoughts about how we can potentially work better together. So that was the title of my slide, how we can work better together to improve cardiorenal metabolic care. And these are some thoughts. So one is training and upskilling. So there is some discussion about whether we should have specialists in cardiorenal metabolic disease, in other words, training a new generation of doctors, specialist nurses, pharmacists who specialize specifically in multimorbidity. But that's clearly something that will take time to develop. It's not something that we can pluck off the shelf now. We can put greater emphasis on multimorbidity in existing training programs, but probably more tractable is to train the people that we have on the ground. So we can upskill, I think, our existing workforce, and that's obviously one of the reasons for meetings like this today, is that we can upskill our existing workforce who are dealing with patients with heart disease, kidney disease and diabetes, so that we can each manage aspects of each other's condition. We can work collaboratively, so I think cross-referral between teams is really important, and something that I know certainly in my region hasn't been working so well in the past, so we can make that better, and we need to develop pathways to facilitate that. And joint meetings and educational events like this are fantastic in terms of trying to facilitate that. So I think we need to move away from single disease sessions and meetings, or at least, if not move away from them, embed multimorbidity sessions and workshops in our specialty meetings. We need to exploit technology and availability of MDTs, and these are established in many settings across the UK, but using virtual MDTs, electronic advice and guidance is really important in terms of spreading expertise and allowing the model in which A specialist nurse, for example, can assess someone with heart failure, but can then join an MDT so that we can discuss the renal aspects or the diabetes aspects further. Working in joint clinical settings is more tricky, so we do have in Leeds, part of our model is to have a joint clinic with a cardiologist and diabetologist. That's possibly not a tractable model. It's fairly resource intensive, quite expensive to run. So I think that's only realistic to deal with a small number of very high risk patients. So we need to think of other options for the majority of patients. We need to include the patients, of course. So this is really important. And one of the learning we found from running our own cardiometabolic clinic is that the awareness of the links between cardiovascular disease, renal disease, kidney disease was pretty poor. So many of our patients didn't know that there was a link between diabetes and heart attacks and heart failure. Very few of them actually knew their numbers, knew what their cholesterol level was or what it should be, knew what their HbA1c was or should be. So there are lots of ways we can improve self-management in our patients. Many of the lifestyle factors and mismanagement are amenable to patient-centered care. And we can use technology to help to do this. So this is already established or developing in terms of using remote monitoring, virtual wards, etc. And I think we'll see a big expansion in this. Specialist nurses, of course, are key to doing all of this. So I think all of you here are really integral to what needs to be achieved. And that's because you have the specialist knowledge in your own area, but can also upskill so that we can manage more aspects of cardiorenal metabolic disease. You're already integrated into local pathways, got good knowledge of local services, and work together as teams, so it's easier for you to cross-refer between specialist nursing teams. I think probably more than consultant-led clinics, maybe even pharmacist-led clinics, you have the patient's trust to help to facilitate self-management, goal setting and behavioural changes. And as I said, I was blown away by the many examples of pioneering initiatives that are underway, but many of those are in single disease settings, so there are huge advances in nurse-led clinics and pathways in heart failure or CKD or diabetes, but less across the board, bringing all of these together. And I think specialist nurses tend to be comfortable working independently, but having support from an MDT to discuss and refer on to more complex patients. So I think we can all think about our own services and how we can improve cross-specialty approaches, MDTs, and upskilling. So just to wrap up, I thought we'd have a look at how things might be changing in terms of the cardiorenal metabolic space and what the next few years might hold. So there are some big initiatives that are underway, and I'm sure the nephrology nurses will have seen this publication by Kidney Research UK. Again, fairly depressing reading, saying that there's a public health emergency and the costs of future renal replacement therapy and dialysis are going to be huge unless we start identifying CKD and initiating strategies to prevent progression. We've got initiatives by the British Society for Heart Failure, and many of you will be aware of the 25 and 25. It's been very well publicised, a great initiative to try and reduce deaths by 25% in patients with heart failure over the next 25 years. And of course there are many other initiatives in diabetes, including those run by Diabetes UK. But again, the problem is these are all specialty-based, silo working strategies. And what we're lacking is joined up thinking about how can we improve kidney disease and heart failure and diabetes at the same time. This is what we need. So is it changing? Can integrated care systems help to do this? Can they bring cardiorenal metabolic care together? Well, I think there's certainly discussions within ICSs and there's opportunities within ICSs, and I know within my own ICS there is now established a cardiorenal metabolic steering group, so there are people working together to try to tackle this, and there are examples of that across the country. This is a report by Patricia Hewitt, published a few weeks ago, and she makes the case that we need to change from focusing on illness to promoting health. So she makes a plea that we need to shift healthcare resources away from treating end-stage disease to prevention. So hopefully
this could happen through the ICSs developing over the next few years. And many of you will be aware of this, the Department of Health and Social Care's new call for evidence to create a major condition strategy. This caused a little bit of controversy because the Department of Health and Social Care sort of moved away from single disease strategies, for example, in terms of cancer detection and treatment, to a multiple condition strategy. And it's caused a lot of controversy and a lot of social media outcry. But what it does is represent some of the long-term chronic diseases. Unfortunately, CKD is missing from this list, but cardiovascular disease has had stroke and diabetes squeezed into it. So there was a call for evidence that closed, I think, a week ago, and as CaReMe UK, we responded to that. I know many other organisations will have, trying to make a plea for bringing together cardiovascular, renal, metabolic disease detection, identification, and management in terms of any future strategy for trying to reduce the risk of cardiovascular disease. So I'm going to end with this slide. So this was an opinion piece, again published a few weeks ago in the British Medical Journal, and this is from Tessa Richards, the associate editor. So she makes the case, following the sort of outcry that the government had moved away from single disease strategies in terms of cancer prevention and treatment to a multiple condition strategy. And she makes the case that this is a really good thing. This really gives the credit deserved to multimorbidity. And she points out that no one fundraises for multimorbidity. It doesn't have a public profile or an army of professional patient advocates, nor does it get much attention from siloed research units or guideline developments. But if patients mention multiple concerns related to their long-term condition to you, and seeing their doctor or nurse's eyes glaze over, and this needs to change. We need less glazing over and more strategies to manage multimorbidity and cardiorenal metabolic disease. So I'm going to stop there, and happy to take any questions.
Does anybody have any questions, or do you have any questions on slide 8, Professor Wheatcroft?
Nothing on slide 8. We put the slide screen up so that people
No.
can see.
Hi, I'm Amelia Cook. I'm an ICS diabetes lead. And some of the points that you made are exactly what I think we need to be doing. So it's sometimes it's quite difficult because you've got teams of cardiologists in the hospital, and they send us messages back saying, do this treatment, do that treatment. I'm not going to pick on one, but you know what they are. And we'll send a message back saying, I'll put that patient on that treatment, this treatment, that treatment. So what we're looking at is these systems being able to work with the hospital. So we've got various ones, share care, etc. So we need to be looking at ways to communicate collaboratively, which is often very difficult. And I think my next point is to get this cardiometabolic renal. I mean, how many years have we been talking about the fact that patients have heart attacks before they die of their diabetes? So just absolutely brilliant talk. Thank you so much. I think I'll take photos of every slide. I haven't really got a question for you, except can we have some top tips from what you've done so that I can replicate that in my area, because I'll be very grateful.
Yes, I'd be delighted to do that. So I think that'd be great. That's something we can do through CaReMe UK, and that's the plan, is to have some examples of best practice and sort of share good practice. And
Thank you, that was absolutely fantastic. So it's a very practical question, going back to your new clinic where you triage to the cardiologist, to the pharmacist, and you may put it up there, so apologies. Just how many of you triaged, and who does the triage? Who did it go to, who does it?
yeah, that's a good question. So the triaging is done by the pharmacist team who deliver the clinic. So they pick the ones they feel comfortable in seeing. At the moment, we're triaging everyone with type 1 diabetes to the consultant-led clinic. We also triaging people who need sort of more complex discussions about heart failure or revascularization. But the majority, I think 80 or 90%, go to the pharmacist led clinic.
So how many?
How many per week?
How many? What are the numbers?
Well, yeah, so this, yes, I don't know offhand, I have to say. The model that we're running at the moment is fairly labour intensive. So the pharmacist-led clinic, the clinic slots are long, so they spend up to an hour with each patient to give them the full time to counsel them, go through medicines adherence, etc. So the numbers, but I think they're running 3 pharmacist-led clinics a week and seeing around 6 patients in each clinic.
Thank you. There's 2 just questions on slide 8 there. So the first one is about funding. Have you had to get specific funding for your collaborative clinic? And have you got any tips for anybody around that?
Well, yeah. So I didn't spend much. So for our collaborative clinic, and in fact for a series of innovations we've done over the years, we've been lucky enough to get industry joint working agreements. So for this particular clinic, we worked with Boehringer, but we've worked with other industry partners in the past, and we're developing or trying to put together bids for other industry partners now. So we have been lucky enough to get joint working partnerships, and they're fantastic. I think they allow you to tap into the skills of the pharma industry, and also obviously it's useful to have the funding coming in to help support them. So that's the way we have gone about it.
Thank you, that's useful. And have you got a trigger tool or risk analysis to identify patients that might benefit from that intensive cardiometabolic input?
We've got some work. So the clinic that we're leading is very much seeing the tip of the iceberg again. So we've got a very focused group of patients with myocardial infarction. But what we are doing, and a colleague of mine working in West Yorkshire, Lancaster here, has developed a tool based on primary care data sets that will pull out and identify the various tiers of risk. So in order to identify patients in primary care who are at the highest risk and then medium risk and then lower risk, to try and strategize and optimize, prioritize treatments for those in the first instance.
That would be really useful, wouldn't it? Thank you. So I think we're out of time, but thank you for that. It's really great to hear of some wonderful examples of what can be done well and your hopes for the future. I hope that's inspiring us all, because I think there's more of us coming together with these thoughts, and we just need to make that a bigger and bigger voice, don't we, to move this forward. So thank you so much.
Thank you very much.